everybody, it's Michelle Boucher, and I'm going to present for you Chapter 2 from our textbook in Murdaugh, Individual Models to Promote Healthy Behavior. What I'd like to do is just present with you some of the objectives of my talk, but I want you to know that this chapter really focuses on models and theories to help explain and predict health behaviors. So when we're talking about the objectives that I'd like to review, we're talking about discussing health promotion and prevention and some of the terms to help understand what that actually means, overview of health behavior change theories, an overview of stage model theory. Very important, especially for this time of technological health, is the digital health implications, and most importantly, what our roles are as practitioners. So when we talk about health promotion, prevention, and protection, we're really talking about the activities that allow someone to promote to their health to become the maximum that they can be. And for people, when we're talking about primary prevention, we're really talking about the reduction of occurrence or prolonged disease onset and promoting health within the limits of illness or disability when we're talking about secondary prevention. Both those should be based on theory and evidence-based practice. Health protection is using regulatory assistance, for example, safe water, but now it extends more to the environmental issues when we talk about safe seatbelts and other preventive health measures. Why are all of these important, these theories for change, is because by understanding variables and mediators and how changes occur and the moderators of how we change things, then we can understand how we can predict and explain health behaviors. And really, we need that to develop health programs that are going to be effective. No one theory is absolute, so that's why there's a presentation of a number of theories that are going to be in this chapter. Now, some of the social cognitive theories and models that we're going to be talking about are the 5 that I have listed. And we've already read some of these in our previous readings by other authors. And my hope is that you will go away with a little bit more of a varied perspective of these theories, and that you'll be able to glean some pearls of wisdom when you want to apply them. So we're going to look a little closer at the health belief model. Proposed in the 1950s, at a time when screening was really challenging for diseases. The biggest challenge was a reluctance to have screening occurred. The model helped identify those who would use preventative measures and those who wouldn't. So basically, individuals will take two actions if conditions are present. One of those conditions are a perceived threat, and then the other is convinced that the benefits will outweigh the potential barriers. When we're really talking about health belief models, we're also including self-efficacy, which is how we build confidence in our ability to perform. It's used to inform and test interventions, especially like education. And why do we use it? It's the ability to predict behavior, which is well documented. Next, we're going to look at the theory of reasoned action. Based on a person's beliefs, that an intent to perform a behavior is considered the most immediate determinant and best predictor of that behavior. So simply stated, when the evaluation of behavior change consequences are desirable, the result is a positive attitude. The opposite is said if the consequence is undesirable. It's influenced by normative expectations of others. So the behavior is under the individual's control was the original assumption, but that is not so in further studying this. So the theory of planned behavior is the next one that we're going to talk about. As stated before, the theory of planned behavior is really an extension of the theory of reasoned action. It's effective in predicting behavioral intentions, which is important. It's based on the perceived behavioral control, which lets the individual know whether it is going to be easy or difficult when performing a particular behavior. Multiple extensions to this theory have been devised, one being the measure of the actual behavior and what is the habit strength. So how easy or challenging will it be? It does have some limitations, especially in its concepts, and because it does have a change in the strengths, it's hard to really validate some of its application in research. Next, self-cognitive theories and self-efficacy is what we're going to look at. Self-cognitive theory and self-efficacy is based on the principle of the interaction of the individual factors, the environment in which the behaviors are performed, and what actual behaviors are seen. Only the self-cognition model is the only one to include the social environment, but it omitted the physical environment, which has made it kind of overlooked in most research using this model. Self-efficacy is important as considered the foundation of motivation. The greater one's self-efficacy or competence, the stronger and persistent you are to engage in a behavior. Now, when we talk about self-efficacy, we're talking about four main sources. The mastery or performance is really the evidence of whether or not tasks can be performed to affect behavior. Modeling is whether or not you can see others be successful or not and what their outcomes are. Verbal persuasion is the most widely used technique. It's to convince others to perform positively or to avoid negative behaviors. And somatic or affective states are really the emotional and physical outcomes of behaviors, and those can be either positive or negative. The last model we're going to look at is the health promotion model. First authored by Nola Pender, she then revised it in 1996 and added 3 new concepts. But it's really a way for us to look at the biological, psychological, and social determinants of behavior changes. Originally, it had 7 cognitive factors, which I've listed for you, and some modifying factors, which I've also listed for you. It's important to understand what the background of the model is so that we can guide and advise the individuals for behavioral change when asked. The 3 new concepts that were added in 96 are activity-related affect, a commitment to the plan of action, and then any immediate competing demands that need to be addressed. As said, the best predictor of future behavior is past behavior. I also wanted to include a schematic of Nola Pender's newer model back from 1996, and it shows going from, on the left side, needing behavior change or to sustain a change, to how to get to health promotion, promoting behavior. Moving from social cognitive models, we're going to talk about stage models of behavior. When we're talking about stage models, we're really talking about trans-theoretical models, since the framework to describe how individuals progress toward adopting and maintaining behavior changes. And there are 5 different stages that are presented. The first is the pre-contemplation. So basically, you're really not thinking about making a change and you have no intent to make a change. Next is the contemplation. So you have some serious considerations that you might want to make a change in maybe about 6 months. Next is the planning and preparation stage. You have a serious commitment to change, and you're planning to do so in about a month. Next is the action phase, and that is the change that will occur in less than 6 months. And then finally, after the change has occurred, it's the maintenance phase, and this is about at 6 months or even greater. Continuing with the stage models of behavior are the 3 concepts that were added additionally to those original stages. These are decision balance, weighing out the pros and the cons, and it's central to this model. Situational self-efficacy, similar to what was presented in the social cognitive theory models, and it's just increasing competence levels. And then change processes. What was used to facilitate change, and how did it help? To use to facilitate change. Important now in this day of age is health technology, especially where it comes to behavior. Some advantages are you're able to interact with a large volume of people. You can use it anywhere that technology is available, as long as you have service. It's available in many languages, and there is anonymity to using it. Some of the challenges are that the individuals have to use it. It's only good if used. Upgrades can be a challenge because it doesn't really allow us to validate a lot of the tools because you constantly are having changes and evaluation would have to be continual. And it's questionable whether there's any theoretical base to any of it. Technology and persuasion theory is really about the ability to change attitudes. Health behavior change support systems are now much more readily available in the form of phone applications or computer programs. They're designed to affect attitudes. And where persuasion is incorporated into them, then it becomes a persuasive system design type of model. Persuasive system designs allow for developing and evaluating of behavior change support systems. So for technology and persuasion theory continued, we have 8 persuasive strategies that we'll look at. The first is reduction. That's to decrease the effort of an individual by making tasks easier for them. Tunneling, which is guiding an individual through a process or an experience to help facilitate their success. Tailoring is making sure that the information is relevant and specific to the user. Self-monitoring is a system for the individual to do their own tracking so that they can keep abreast of their own progress. Suggestions is just offering suggestions and alternatives to ways to be successful. Reminders can come in the way of text or even calendar alerts. Social comparisons are when we are comparing ourselves or when others can compare themselves with similar issues and see how they rank and how they compare. And normative influence is just peers with similar goals and issues will be able to compare to each other, providing a network of support. So how else do we help? Well, it presents some of the strategies to change health behavior. So what we want to do is make sure that we're setting goals and helping the individuals to set them as well, making sure that they're realistic and obtainable. We also want to monitor progress, recording behaviors and making sure that they're completing self-evaluations. We want to promote that confidence and that self-efficacy. We want to enhance the tangible benefits, have them see what they may be overlooking, to manage the barriers and to help them move those obstacles out of the way so that they can be successful, and to help tailor communication so that it best resonates with them. Now, with a lot of the changes in technology and a lot of changes in these behavioral theories and models that we'll be implementing, we have to think about the ethics and what the health change would end up in being and how it would be impacted. The ANA has a code of ethics that we follow, but there are some common ethical issues that we really need to be cognizant of. We need to be aware of personal responsibility versus government obligation. We need to be aware of persuasion tactics and make sure that we're not coercing somebody to do something that they may not be comfortable doing. We want to make sure that we're aware of cultural sensitivity so that we're acting not on our own beliefs but on the individual's beliefs to make effective behavioral change, and make sure that we're also avoiding labeling and stigmatization when we're dealing with individuals. It is not our biases that we should be putting onto them, but it should be what their beliefs are, and make sure that we remain impartial and fair and understanding. In summary, we're all change agents, and we really want to choose the best model to cause change for positive and more effective healthcare behaviors. These theories and models that I've presented are all evidence-based, which is how we all want to be practicing. Our responsibility as nurses is to make sure that we're practicing with guidance and that we offer counseling so that those in need of behavioral health changes get what they need. Thanks.